Hi, my name is Aljo Adolfo, and I'm going to show you a quick video about tracheostomy. For tracheostomy indications, we have airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, and the treatment of obstructive sleep apnea. So for the surface landmarks, run your finger up the midline of the neck, starting inferiorly at the sternal notch. Identify the thyroid prominence or Adam's apple, and moving inferiorly, the finger slips into the depression of the cricothyroid membrane, followed by the solid prominence of the cricoid cartilage. The incision should be placed 1 finger breadth below the cricoid prominence or 2 finger breadths above the sternal notch. Place the patient in a supine position with neck extended by a pillow or bag placed under the shoulders to deliver the trachea out of the thorax and to give adequate access to the cervical trachea. Sterilize the skin of the anterior neck and chest and drape the neck. Make a horizontal incision 1 finger breadth below the cricoid prominence. It is cosmetically preferable to do a vertical midline incision. Extend the incision through skin and subcutaneous tissue while taking care not to transect the anterior jugular veins, which are superficial to the strap muscles within the investing cervical fascia. These can be preserved and retracted laterally. Dissect towards the trachea by parting the tissues with scissors, remaining strictly in the midline in a vertical plane to avoid injury to the inferior thyroid veins. Identify the midline cervical fascial plane between the sternohyoid muscles. Divide this intermuscular plane by spreading with a pair of scissors. You then identify the sternothyroid muscles and you retract the muscles laterally. Doing this, the trachea and cricoid can now be palpated. You retract the isthmus superiorly with Langenbach retractors to expose the trachea. In the awake patient, inject lidocaine into the tracheal lumen prior to incising the trachea and inserting the tube to reduce coughing. The safest tracheostomy in adults is to create an inferiorly based flap raised from the anterior wall of the third and fourth tracheal rings. Blood is suctioned for appropriate visualization of the trachea. A silk traction suture is passed through this anterior tracheal flap and loosely secured to the skin. Assess the size of the trachea and insert the largest cuffed tracheostomy tube. The obturator is then removed and then you insert the introducer into the tracheal tube. Remember to inflate the cuff attached to the anesthetic tubing. Correct placement of the tube is confirmed by checking the expired PCO2, checking for chest movement, or listening for breath sounds. Thread tapes through the holes in the flanks of the tracheostomy tube and pass them around the neck. Remember to tie them with the neck flexed. If the tapes are tied with the neck extended, they will be too loose when the patient flexes the neck. The ties should be tight enough to admit no more than a single finger under the tape. Suture the tracheostomy tube to the skin for the first few days until maturation of the tracheocutaneous tract is accomplished. For contraindications, we have an absolute and relative contraindications. Under absolute, we have skin infection and prior neck surgery. And under relative, we have laryngeal carcinoma, severe coagulopathy, short neck, and obesity. For complications, it can be divided into early, late, and delayed complications. For early complications, we have bleeding, pneumothorax, pneumomediastinum, and recurrent laryngeal nerve injury. Late complications include accidental decannulation and infection, while delayed complications include the thinning of the trachea, tracheoesophageal fistula, and narrowing of or collapse of the airway above the site of the tracheostomy.